Welcome, you are in the right place. In just 1 second, I'm going to pass it over to my colleague Niti, my co-host, who will tell us a little bit about how we can get started today, because the appointed hour is here.
Welcome, everyone. Here we are at our 47th webinar, our first for 2025, and we will be talking about task shifting in cleft speech care. And we have with us Dr. Debbie Sell and Professors Valerie Pereira, Rupa Nagarajan, and Subramaniyan B. We will be having interpretation in Spanish. For the entire duration of this webinar, we have Ben and Eva joining us from Chile for the translation. At the bottom of your screen, you will see an interpretation button. If you would like to hear the rest of this webinar in Spanish, please select Spanish. If you would like to continue in English, please select English. Who are the COCP? So we are a network of over 950 cleft professionals from 90 countries who have an interest in promoting comprehensive cleft care in resource-constrained contexts. Here are the 11 international charity organizations whose collaboration and collaborative efforts have made the COCP and all of its activities possible. We are deeply grateful for their partnership and support. We will now be having a presentation from our 4 panelists for the first 25 minutes or so. This will then be followed by questions and discussion for the remaining half hour. Hugh.
All right, I'll just remove your spotlight, take the spotlight back. So again, my name is Hugh Brewster. I'm here in Toronto on behalf of the Circle of Cleft Professionals. I'm delighted that you're with us for webinar 47. And the focus is on a conversation that's really important for many cleft teams around the world. Just talking this morning about how even in a country like Ethiopia, where they've seen some enormous strides forward in having trained speech therapists available in the country, we're also seeing teams that are developing, drawing on the talents and the interests of speech assistants. So the sense of how we manage the differential placement of speech therapy trained people around a country or in a region is critical, and then how we cover off and how we ensure that some of the speech needs that are being presented by families affected by cleft are really being well managed. So I'm delighted to have our guests today talking about task shifting in cleft speech care in resource-limited regions, status challenges, and future actions. As you'll see on the right, we've got 4 esteemed colleagues who are going to lead us through this conversation. We've got Dr. Debbie Sell, who many of you will recognize as an editor of the ILP journal, of the ACPA journal, the CPCJ. We've got Professor Valerie Pereira, who's the chair of the Cleft and Craniofacial Committee as part of the IALP. We've got Professor Rupa Nagarajan, no stranger to anyone around these parts, and as an advisor to the Circle of Cleft Professionals. And then Professor Subramaniyan B, who has done some cleft-specific speech therapy work in many countries and is based in Chennai, India. So we are delighted to hear what they've come across from their paper that's recently been published, as well as leading us towards the sense of challenges and future actions, which I'm really excited about. So I know they've left quite a bit of time today for us to talk about what this looks like in our own regions and respond to some of the discoveries that they've made along the way of researching as part of the task force that emerged from the Edinburgh conference not too long ago. So without further ado, I'll pass it over to our first presenter. I think that's Professor Subramaniyan. Suraj, please take it away.
Hello all, can you hear me?
We can hear you, Suraj. Perfect.
Okay, thank you. So hello all, New Year greetings. I'm Suraj, a speech language pathologist from India, having an opportunity to work in LMIC and then also have collaborators from different parts of the world. So with me today, we have 3 other collaborators, Dr. Debbie Sell, Dr. Valerie Pereira, and Professor Rupa Nagarajan, are here to share about our work on the task shifting, the resource-limited region status, challenges, and future action. So this presentation is structured in 3 parts. The first part, which I will be doing, giving a brief introduction to the work we recently published, so that the participants who are here can get a background of where this particular webinar is coming from. And then our particular emphasis will be on what we learned from this process, which will be presented by Dr. Sen, and the way forward, which will be presented by Dr. Valerie. Next slide, please. So where did it all start? Following an invitation from the International Confederation of Cleft Lip and Palate and Related Craniofacial Anomalies, ICCPA, for the CLEFT 2022 conference. The first step was as to form a speech task force group. So that's how this speech task force was formed. Next slide, please. Okay, so I'm so happy that many of our task force members are here. We identified this core group of speech language therapists who consented to participate in this task force. They represented 13 countries across 5 continents. This work is a collective efforts of all these members. And I'm so glad that they are here and they'll be share their experience during the discussion part. Thank you. Next slide, please. So to give an idea about the timeline of this work, this began in mid-2021. And how did we conceptualize this? Our focus was to identify a topic which has a continuity to the work of the previous task forces and a topic of significant relevance, which we could start and complete in a time frame of 6 months for it to be presented in the CLEFT 2022 conference. And how did we do this? We identified a process, consensus building, and a lightning decision jam was used to identify the topic for this task force. These sessions were led by an external facilitator, Mr. Ramal Pereira, who is an expert in developing consensus among a group. Next slide, please. So the first step in building this consensus was getting an idea, voting, and prioritizing what we would like to identify as a task force topic. So the members of this particular group brainstormed and identified many topics, as you can see in the slide, and then voted on the topic of significance, which this task force group would like to take this and go forward. And the next stages, next slide, please, Nikki. In the next stage, the voted topics were graphed on an impact effort graph, which maps the amount of impact of the topic and the effort it would take to achieve that. So based on this, next slide, please. From this process, task shifting emerged as a theme for this task force. This group of SLPs focused on examining speech language therapists and non-speech language therapists who are drawn into deliver speech services to clients with cleft lip and palate where there is an absence or scarcity of speech language pathologists. Next slide, please. So the aim was to establish the different types of service providers delivering speech language therapy services across the regions and different models in resource limited region. And secondly, to profile the roles, tasks, knowledge, and skills of each provider, thereby defining a scope of practice document. Next slide, please. And how did this group achieve this? This group met online over 15 times. And the first question which we tried to answer was profile the different types of service providers who are involved in providing care across the regions. As you can see in the slide, we identified 5 levels of service provider. In that, there were 3 levels of speech language therapy providers who could be grouped under specialist SLP, who's working in a cleft care team, or a generalist SLP who's providing speech care services in the region, or a speech therapy assistant. And there were also 2 non-speech language therapy providers who are identified as either grassroots workers or paraprofessionals involved in providing care. Next slide. And where did we find them? And this is a snapshot of where these workers, where these different types of service providers are involved in providing care. It was good for us to notice that the task shifting as a concept was there in both high-income countries and low-income countries. But in high-income countries, what has happened was they had a structured mechanism on the monitoring process to identify or to observe the work carried out by speech therapy assistant. Whereas in many regions in Asia and Africa, all types of service providers were involved in providing care, and especially the non-SLTP ones had minimal or no training, but involved in providing care. Next slide, please. So what happened next? This highlighted the need for a common understanding about the required knowledge and skills sets for the different providers. And that was taken as the second objective of our work. This task force, what did we do? We worked on developing a document to map the services provided by the different providers and identify their scope of practice, especially including the activities which are not permissible or appropriate by that service provider. I have provided one example here for a grassroots worker, which describes their work setting, the roles, tasks, knowledge, skills, and services which they are not permissible. This information is available in the publication which we publish, which gives information about all the 5 different set of providers. So now here I have given an idea of, I've given a background of where this work has come from, and I shall now hand it over to Dr. Sel to present our learnings from this work. Thank you.
Thank you. Hello, everybody. So what did our task force learn? Firstly, we reflected that we were the only profession in the cleft team to train and use other providers with no background in the discipline and no SLT supervision. So the non-speech and language therapists or pathologists, called the non-therapists from now on, providers, had no consistency in the use of titles. The same title meant often different things to each of us, and there was high variability in what they did. So, for example, a good example is the assistant, which in the high-income countries, this is a recognized, regulated role, and it's part of the speech therapy workforce in which the speech therapist does shift tasks to the assistant. But that assistant has a job description, they have appraisal, they have training, they have supervision. As a result of this, then, there was no documentation of these non-therapist providers' scope of work, and it was very challenging at times for us to get a consensus amongst our group, as we were all victims of our own experiences. And furthermore, there were very few studies of the effectiveness of non-therapist providers using internationally agreed standards of speech outcome measurement. And in particular, for example, the need for recordings pre and post intervention and using unbiased blinded listeners to evaluate outcomes, and not the therapists or the workers who have actually undertaken the intervention. Next slide, please. So this also allowed us to reflect, oh my goodness, as we broke down the roles, how difficult cleft speech intervention is, even for the experienced therapist at times. It's much more complex than just repeating and practicing sounds and words. So some of the things that the trained therapist does while they're intervening, while they're having therapy, is they've got excellent listening and phonetic skills. They're working out what's happening in the mouth of these patients. They've got lots of tricks based on what they've worked out to elicit sounds. They prepare a program. They know how to make a task more difficult, an activity more difficult when it's too easy, and equally if it's too difficult for the patient, to step it down. They work as much on output, i.e. speech, as they do on the listening side for sounds. They're creating innovative ways, because there's so much repetition, of engaging the patient in still practicing. They ensure that the child or patient has a good sense of success and not failure when these things are difficult to change. They know when therapy and surgery is indicated. They know when to stop therapy. And there are patients who we just have to say we can do no more. They have a holistic approach to this whole individual. And of course, they do training of parents, teaching assistants, SLT assistants, significant others in the patient's lives in order to encourage this practice. So moving on then, we go back to task shifting. Next slide, please. And Letters from the WHO 2008, excellent publication, which has really stood the test of time. Look at the definition that they give us. Tasks are moved from specialist health workers to other highly qualified health workers from a different professional background, for example, the surgeon in our teams, but more usually newly created cadres of workers or non-health workers with fewer qualifications, and importantly, supported by supervision by the discipline. Next slide, please. So if we look at this report and a subsequent Cochrane review, we can see some of the elements that are needed, some of the standards in the guidelines, and it talks about a national framework to ensure quality standards and accountability. The need for appropriate funding and sustainability, standardized, simplified protocols, simplified reporting and recording systems. Needing the definition of roles and responsibilities and skills and competencies, recruitment criteria, standardized training and ongoing training, supervision and evaluation, not only just of them as being able to deliver, but also the outcomes of that delivery of whatever the healthcare that has been shifted to them. And importantly, another publication, which is fascinating, actually is a qualitative study of the perspectives of health workers to whom the tasks have been shifted and their input into how we improve this process. So next slide, please. So there are several examples of cleft speech task shifting examples in lower middle income countries, and particularly in assistance and the complexity of that, as we've already described, and community workers. And many of you on this call have been involved in these hugely sort of worthy ad hoc initiatives to try and provide services, but many do lack some of those elements that we've just gone through in the task shifting framework. Next slide, please. So our paper is just a start, trying to understand and get some structure to the confusion in this area. And we can see in yellow what we've achieved in our paper. Definition of roles, responsibilities, something about skills and competencies, and importantly, knowledge of what is not in that role. Next slide, please. So going forward, we have three areas that we're thinking of, and that is advocacy, which is working towards consensus on the work to date. And even since we've developed this paper and worked together as a group, there have been more publications, and we need to bring on board some of that new stuff. We want to really support and encourage regional interests at whatever level in developing speech services, and to collaborate where there are with the regional speech and hearing associations, and collaborate with the ILP. This is the International Association of Communication Sciences and Disorders. It's like the world group of speech therapy, if you like, and it's really got some important areas of work. Sustainability, we cannot do this without proper funding as well. And importantly, to keep in mind that our aspiration must always be for the development of academic programs in speech and language therapy. And these are occurring all the time. And there's a lot of expertise out there, which we know of, that we can access to if people are interested in, or at a starting point or on that road, to put people in touch with each other. And importantly, the IALP has an education committee, which actually has a paper around developing services. And then, of course, the final point going forward, and Val is now going to talk to us all about these areas here: teaching, training, supervision, mentoring. And over to Val, please.
Great. Thank you, Debbie. Just to set the story straight, I don't have any answers. So what I'm going to do is just to tease out more components in terms of the terminology, training. We see the word training used a lot in the task shifting literature. So what I'm going to do is tease out the several components and then look at what we have in terms of models of teaching or coaching or supervision. I think the takeaway message at the end of this is we don't have to start from scratch. I think there's sufficient experience, evidence around globally that we can draw from or use as a platform. So when we talk about training, there are essentially 4 components that we do actually need to consider and include in this whole training or education. So we have teaching, which is about transferring content or what we call input knowledge. Coaching, some people call this training, which focuses on applying the content knowledge or input knowledge to practice. So that's your clinical skills. Supervision, which we know is a process where the supervisor provides guidance and feedback. And of course, mentoring, which, as we know, is about development of the mentee, both clinically and professionally. So the sequence, if we can call it a sequence, is not linear. It's obviously not set in stone, and there often is a return to teaching and coaching, just like with any of us, to increase knowledge, skills, and continuing professional development. Next slide, Lindsay. Thank you. So as I said early on, thankfully, we don't need to start from scratch. There is quite some evidence around that we can draw from the literature. So if we look at examples of current models, we have the hybrid 2-stage training by Crowley and colleagues. And for those of you who have not read their published paper, they have a 2-stage process. So stage 1 involves the online cleft speech course, which represents the teaching part of content or input knowledge. So about cleft palate speech, about intervention. Stage 2 is their in-person training, and in their model, they have 2 parts. So whilst on site, they review the content knowledge that was covered in stage 1, and then they move on also to coaching or training of skills. So applying the input knowledge to hands-on practice and the clinical context. There is also the task-shifted model by Lindeberg and colleagues. So this was a 1-week speech camp, and it's undertaken by Nepalese speech-language therapists training speech assistants. And in this context, they were auxiliary nursing midwives. Now, the SLPs also provided supervision and coaching. Then, of course, we are all familiar with this third model, where you have cleft specialists or cleft experts from cleft teams in high-income countries visiting LMICs. And here you have the components of teaching, coaching, with subsequent online support, which I suspect would cover the supervision plus minus mentoring. Oh, next slide, please, Niti. Thank you. And in terms of mentoring, there are 2 current mentorship programs. Just to also say that what I'm covering now doesn't mean that I've included everything. So it's just to highlight certain models or programs that are around. So the first one is the fairly well-known MAGS program by Smile Train, which is aimed at speech practitioners at all levels of skills. And mentors are cleft experts in speech treatment, and mentees must have some foundational skills or knowledge in cleft speech treatment. So they need to undergo or look at the online self-study course, which is about 8 hours, if I'm correct. And then, of course, they require further guidance and insights from the mentors, particularly for more complex cases and any queries they might have. What is interesting in the paper is that examples of mentoring topics include assessment, resonance, so on and so forth, which further exemplifies that the sequence of teaching, coaching, supervision, mentoring is not linear, and there's always the opportunity and leeway to go back to reviewing content knowledge or further acquisition of knowledge and skills. Next slide. Okay, So another mentoring program is the Transforming Faces IALP Speech Mentorship Program. Debbie's already talked about what IALP is, and I will introduce our CLEF committee in the next few slides. And thanks to a lot of work and effort from Niti's part and Transforming Faces. So the mentorship program began in January 2021, and we have recently just completed our third round. And each round is about a year, lasts for a year. And in each round, we have about 20 to 23 mentees and about a similar number of mentors. Now, mentees, as you can see here, must be speech-language therapists within 7 years of clinical practice, live in a LMIC resource-constrained country, and a proportion of their clinical workload has to be dedicated to cleft and palate. Now, what's a bit different in our mentorship program is that mentors do not have to be cleft experts. As you can see here, they have to be very senior. They have to have the experience of supervising, mentoring, supporting junior colleagues. And what would be a benefit is if they had SSD or speech sound disorder experience and or dysphagia. Now, a number of mentors are typically from the CLEF committee, and pairing tends to be based also on logistics and time zones as well. So what I'd like to share next is just some results that we've had from the second round. So what we do at the end of every round is Niti would send out a survey, a questionnaire, and you can see some examples of the questions, and these are all rated on a Likert type scale. So I've only picked out the two that would be very relevant to what we would term as mentoring, and not so much teaching or coaching. And you can see from these two slides that most of our mentees reported that the mentorship program has contributed to their professional and clinical development, with the effects transferring to their clients as well. And this is a feedback not just about mentors who have cleft expertise, but also senior experienced SLTs with no cleft expertise. So maybe perhaps when we get to the mentoring component or the mentoring phase, perhaps we don't need someone who has that much cleft expertise. Right, okay. So the next slide, right, as I said, I don't have the answers, and I hope you do when we have the discussion part, or probably more questions or issues will arise. So Debbie's already mentioned that the plan is for the Cleft Palate and Craniofacial Conditions Committee or subcommittee of the ILP to move this work forwards. Okay. Here are our members, and I'm very sorry to say that I just realized that Selina Young, who is in in this room, somehow I've missed out your picture, Selina, so I'm very, very sorry. But if you want to know what she looks like, just look for one of her squares and you can see her. So the work, why us? Why the Cleft Palate Committee? The work adheres very closely with the organization's core strategies, which, as you can see here, the relevant ones are networking, educational programming, and Debbie talked about advocacy and partnership as well. Perhaps more importantly is the diversity and experience of the group. You can see that our members come from all over the globe, many of whom have direct experiences in working in LMICs, in task shifting itself, training of cleft speech intervention to non-SLPs or paraprofessionals. And what you may also notice is that we have representatives from the various relevant groups and organizations. So such as MAG, Smile Train. We have representatives who are in Operation Smile, or who do lots of work with Operation Smile. And obviously we have members who have very close collaboration with Transforming Faces. Okay, next slide, Missy. Thank you. So the final slide, there are indeed no shortcuts, as Debbie has pointed out earlier. Perhaps a good starting point is the teaching component. So developing materials and content for this teaching component. And of course, what may be a bit different from current teaching or training models that are around, that we are very focused, and what we do want to do is to ensure that this component is differentiated for the different levels of service provider, which Suraj introduced at the start of this presentation. And of course, as well, something which Debbie mentioned, that it would be extremely necessary that there should be proper measurement of outcomes, perhaps somewhere along this process. So on that note, I'm going to hand this back to Hugh for the discussion session.
Excellent. Thank you to all our presenters. Valerie, thanks for passing it along. There is so much to discuss here. We've got a huge turnout of people with lots of investment in cleft therapy, speech therapy on this call. So as always, we'll take the chance to digest for a second. Think about your own comments, observations, questions, and then we'll move into, feel free, you can wave your hand. You can use the feature that allows you to raise your hand, or you can type your question or comment into the chat and we'll deal with it. A reminder, we have many people from Latin America who might feel more confident or comfortable speaking in Spanish. So even if you're hearing me in English, you'd like to go down to the bottom bar and select English. So that means that if someone does speak and ask a question in Spanish, you'll hear our trusted interpreters from Chile who will will translate from Spanish back into English. So just make sure you do that. And then, yes, you're very welcome to ask your question or make your comment in Spanish as well. Great. Who would like to kick us off here? Comment or question? All right, I'll get us started. So one thing that really struck me was the term ad hoc in your presentation panel, and definitely in terms of my experience in being a real fan and supporter of the benefits of speech therapy in terms of cleft, that sense of moving from when there's nothing, there's no way of patients getting any kind of treatment in terms of their cleft, that journey from ad hoc into moving into assistance, and then potentially even having a trained speech therapist as part of that journey has been something I've observed in quite a few places. And so I guess my first question for the group is, what is that first stage, that gets you on that journey? What did you discover in terms of that task shifting approach? Of moving that sense of having really nothing that's there. And we even have some people on the call like Adiola, a trusted colleague who, not seeing any kind of trained speech therapy in her region, actually took some responsibility as a surgeon even of learning a lot more about speech therapy going on. But what's that journey from ad hoc into that first stage of providing some basic element of care for speech? And I'll open up. Anyway, Suraj, you have some experience even in equipping some volunteers, some community workers in that. What's been your experience in terms of moving in a community from having no specific kind of speech intervention into having some?
I think I'm going to talk about what happened 15 years back. From that perspective, I'm going to give you this answer. Yes, at that point of time, there was no available service in that region. So we had to start with something. And the one thing which we all learned is there was a consensus workshop which was done before implementing this program. And that program highlighted the need for training and continuous monitoring. I think that was the advantage of the model which we were implementing in South India, where we knew that what to train and the training was provided in different stages. People were not given directly or taken into provide as a speech correction program provider. So they were involved in, can they identify anybody with a cleft? First point. Second point, if they see, can they identify the speech is different from others? Number two. So that was something which we started with initially. And slowly we moved into a phase. How can we make sure, how can we train these people to implement what has been told to them? And that's where we started. And I think the one advantage we had was we had an active academic group and active program which could support this community-based program by providing frequent monitoring and then review and then try to understand what are the future needs of the community. I am ready to provide. Is the community ready to receive? And what are the challenges in doing that? So I think that's how we started on running the program, and it has moved into different forms and shapes. And now the geography of where we are working is totally different. And it is important for us to introspect and see, is that how we do, or what more quality indicators which can be brought into this program. Maybe Professor Rupa can add to this point.
Thank you, Suraj.
Thanks.
Go ahead,
Thanks,
Professor
Suraj.
Rupa.
Yeah. So I do want to say that, our 2003 consensus meeting was mind-blowing to me. It was the first time I was involved in actually thinking about how do you provide a service somewhere else. And we learned from community workers and programs from other programs, not at all related to cleft. And, I agree with what Suraj said, but actually now doing this task force, I guess about 15 years after we did that first program, suddenly, demonstrated to me, and I think for many of us on this task force, was there really is, work going around the world in levels, and we need to take the chance to look at what can be done at each level and how do we push a particular region. And you take an example of a place like India where there were few cleft speech therapists, many programs. So how do you push the boundaries to get more types of models so we can reach more children? Obviously, even 40 SLP is not going to be enough for the number of children with cleft we have. So how can a speech pathologist really push the boundaries to look at different models they can use? And I look back at our own model that we started to say, have we done enough to move forward? Have we done enough to try more different things? So I think this task force really, and it's so lovely to see everybody here. I think after a long time, we're getting together. So it was really a learning process for us. And I truly enjoyed it. And I think you have to go and understand what you have on the ground and work with that. It's how much the region response to you is as important as what you want to do. So you need the government on it, you need the people on it. Yeah.
Yeah, I think it's so easy to look at what's there and some of the things that have been discovered by your committee and think, oh no, we're not hitting the mark. But I think in a lot of ways we're thinking this is, as you mentioned, this is an evolving community. So things that made sense 20 years ago, 5 years ago, depending on your context, they were great. They're a start. They're moving in the right direction. And now, how do we assess? I mean, I think there was that real push from Professor Valerie's point about how do we know if it's working? What's the outcome, and how does that inform what the next stage might be? So I think Krupa has a great comment in the or a challenging question in the chat. What is that sense of how if we're equipping people to do some of this task shifting speech work? What are the implications of if we're not able to provide some of that ongoing supervision? And so I'll push that back. And again, anyone else on this call, I mean, lots of us in different regions have responsibility. So please use the chat to comment in. But that ethical dimension, Debbie, do you want to jump in on that? How are you feeling about this?
It's a really, really important question. And I think actually by having that structure of task shifting, which the WHO has published, we've got more of a framework to understand now what those processes are that are happening. And I think we're learning ourselves. We don't have the answers to this at all, but it's trying to make some sense of the confusion and to get some overall picture so that actually we do have common understandings amongst us. And where there are non-speech therapists, doing speech services without supervision, we should be concerned about that. And we need to be trying to think about how can we support. So yes, that's, I think, mostly what I'd say there. In terms of the boundary question that you asked, we, in some ways that was a little bit easier than some of the content. And the group tended to, we discussed all of it and we came up with what we thought were the boundaries. They are, again, up for discussion because we want to get more consensus on these issues. And in terms of involving local stakeholders, we presented the work in Edinburgh, where we had a question and answer session, and also a little survey poll within the in the presentation. So we have tried to get information from stakeholders, but there's a limit to what one can do when this is all unfunded work and we do it as volunteers. So a lot of speech therapy, I might say. So over to.
Thanks, Debbie. Yeah, no, helpful. Again, please feel free to push your comments or questions into the in the chat, or signal that you'd like to speak. Tim, as a provocative question, or just building off some of the observation, is that it'd be unthinkable really that a dentist would say, I'm kind of busy today, or I can't come back, so I'll just have you do a couple extractions. You volunteer. What does that mean about speech therapy? Is that a strength or is that a weakness? How do we think about this idea that speech could be covered? And I think one of the slides that you presented was that speech therapy, is much more than simply repeating sounds or about coaching to form a mouth in a certain way. We're moving beyond that in terms of that ad hoc element. So what is the inputs that are required? Itzel, I see you from Jeffrey, please. And if you haven't clicked the Spanish, I suspect this will be in Spanish. So go ahead, see. Itzel, go ahead. Yes, your question or comment.
Hola, voy a hablar en español. Buenos días, buenas tardes. Quisiera comentar que es muy interesante lo que estamos observando y que yo he visto en mí misma el impacto de tener supervisión, mentoría, ampliar mis conocimientos académicos para poder acompañar y mejorar el servicio en donde yo trabajo, que se llama CEINAL, en Chiapas, México. El 2023-2024 me llenó de estas oportunidades y diría que mejoré en un 100%, 200% al tener todos los apoyos, tanto de la práctica, el colaborar con otros expertos, tener mejor conocimiento académico, y durante la mentoría en TIEF, la supervisión, que fue Karen quien estuvo acompañándonos, y entonces es un cambio al 100. Yo era un Itzel antes de este proceso donde también trabajaba mucho en lo individual, sin estar conectada con el equipo interdisciplinario. Hoy lo que yo aporto al equipo, a los cirujanos, a odontología, a trabajo social, es mucho más significativo para impactar en los niños y sus familias. Así que yo podría decir que he vivido la experiencia y es genial. Yo quiero más de todo esto.
Thank you for that. Thank you for that amazing testimony itself. So again, just for others, this is in a region, a lower resourced region of Mexico. Itzel is a trained speech therapist, but not necessarily having access to supervision locally. So tapping into the Smile Training Network, tapping into other elements, and that sense of how supervision could be provided, even if it's not directly on site, has led to tremendous growth in her own practice as a cleft speech therapist. So thank you, Itzel. Wonderful. I see Triona and then Adiola. Love you to jump in.
Hi, I just wanted to go back to Tim's comment about speech therapies and the way we work. And to a certain extent, our work is very different to everybody else, because even if we're seeing a child twice a week or 3 times a week, we're still dependent on parents or somebody doing practice and routine drills with these children at home on a regular basis. So it's really, we're taking that, I suppose, that concept of we can plan and we can supervise, and somebody else can actually do it provided they're supervised. I think that's the big difference between us and other members of the cleft team. And thanks for a great session, Hugh. This is really, I'm really enjoying it.
All right, excellent. Thank you, Trina. And I'm putting something here in the text, but I think oral health professionals might also say there's some work that has to be done at home also on a regular basis for good oral health also. Adiola, thank you.
Yes, thank you, Hugh. Thank you, everyone, for having this presentation. It's really been exciting. I just want to mention that in my locality, like in Nigeria, we do have a number of SLPs, but the challenge there is that there are practically very little number of them with expertise in cleft speech therapy. So we do have the SLPs, but having cleft speech therapy expertise was a challenge. And as Hugh mentioned earlier, I'm actually primarily a surgeon. And what drove someone like me into cleft speech therapy, which is pretty lovely, by the way, is the fact that after the surgeries, the patients were not improving. And a lot goes into that surgery. And these patients have been referred to speech and language pathologists in my locality. So that was what, should I say, piqued my interest in it. And so far, this had been like for quite a number of years back now. But so far, what we have realized is that though we do have the SLPs, is the expertise in cleft care that is lacking. And the other aspect is that even the few that may have expertise in cleft care, the experience, especially the older SLPs would understand what I mean by this. Having an experience in cleft speech therapy, having a wider view of patients that you have seen, because usually one patient is not similar to the other. They have like different, and that comes with experience. Unfortunately, I don't think we really do have like a cookbook that a new person can go into and say, when someone presents like this is how you go. So we really do not have that yet. And I think it's growing. So that also has been a challenge. But I can understand the challenges with task shifting. And it would be nice if one can, educational programs, undergraduate, have the SLP undergraduate students come to have a feel of this. And by the time they are graduating, they can even decide to go into cleft speech therapy. Thank you.
Thank you, Adiola. So you're another context again, right? Where there are now in Nigeria locally trained, academically, certified speech therapists who may not have any exposure, or even desire to learn about cleft. And we see that a lot, even, oh, you're a speech therapist, you're in this country, you must get involved. And they're like, I'm not interested in this. This is too complicated. I don't feel like I've been exposed to this. This was maybe 1 hour in my whole undergraduate or master's, 1 unit. And it seemed complicated, and I'm going to do other things. So I think Adiola is pointing us to that sense of advocacy that was where the task shifting presentation ended, thinking about how do we motivate, how do we advocate, how do we ensure that we have the resources, how do we retain, when people have this kind of experience in cleft and this passion that's shared on this call, how do we make sure that these people are getting opportunities to grow and be supervised in learning? Now, Adiola, just one quick rejoinder to you. So what does supervision look like, for you in your area in terms of, when you do have a speech therapy or someone trained in speech therapy like you, to be able to talk with someone else with other kinds of experiences about treatment plans and outcome measurement?
So what has been going on in my environment now has been mainly pushed out by Smile Train. There's the MAGS mentorship program, which and also Professor Crowley, her training. We do have our community whereby we discuss cases amongst ourselves and then a way forward. But personally, what I do in order to improve is that I have in our speech group, cleft group, I have speech language pathologists who are lecturers in the university and who are interested in the program. So they come and we reason this together and then manage patients together. And hopefully I would more or less step aside and then, because they are more or less like younger SLPs. So they step aside and then they take the whole program to the heights. So that's what we're doing now.
So that's your own ad hoc solution and a really important one, but again, it pushes us again to say without someone of your profile and your personal connections, right, this would be difficult for others to implement. So how do we move forward in that sense? So there is that community element. I see Trina has posted back to the ILP. You mentioned Kate Crowley and Smile Train's resources that are there. So there are things that are there, but I think that interpersonal element of it is so important in terms of, compensating a little bit or even enhancing, even if there is that supervisory structure there, how do you enhance that? And I'll do a plug back for the Circle app as well as a one particular place to sort of get connected and to kind of keep some of those discussions moving forward. Thanks, Adiola. Other comments we've got. Dr. Hussein from is saying here, how can we ensure that non-professional providers delivering speech language services receive adequate training and supervision to maintain high quality care while also preventing the misrepresentation of qualifications in that sense of, erosion of trust and malpractice, et cetera, et cetera. So, I'll go back to our panelists. One of the things that I found really exciting about your presentation was presenting a typology of those different levels. How would you say that at least what's your further comment on that sense of at least getting our titles right of what we mean by assistance or what we mean by a trained person or what we mean by supervision? I'm not sure who would like to jump in there, but tell us a little bit more about what you uncovered or what the consensus was within your task force about this typology.
Yep,
Debbie, I see you smiling. So Debbie, please jump in first. Suraj, you can add something.
Suraj, I think you've got something you can say.
Perfect. Suraj, jump in, please.
I think that as a group, we had tried to put in a lot of effort in getting that framework. To be very honest, it was very difficult for the 13 of us to come to a consensus in how to fit this. It was a very, very difficult task for us. So I think what Dr. Sel mentioned, it is a very, very first step to identify the scope of practice and all of that. And we had also mentioned that this requires, revisit to see, what are all the perspectives which needs to be added or deleted. And yes, the very purpose of coming up with this framework is to provide a document for organizations or regional, governmental organizations who are implementing speech language programs in their respective regions. And if there is a country who is in it at the level of starting cleft care, and this can be used as a model, identify what is the human resources or the system available in that particular region. And you have a basic version to see who can be mapped, at which level we have. So you have a basic document to look into. And when you identify somebody as SLT, and you also can ask questions, what are the deliverables from that person? From that perspective, this document gives a baseline of what is expected, and more importantly, what cannot be done at that level.
Yeah, so it's a really important discussion for us to wrestle with. I mean, I think one of the things that really occurs to me as someone involved in funding decisions for certain cleft teams is even that sense of self-assessment. How much further could we go if we're asking someone to attend to some element of speech service? How would they assess their own practice at this point in terms of their ability to have teaching? How much coaching or training do they feel like they have, and how much do they need? Do they feel like they're adequately supervised? Can they draw on that? Are they involved in a mentorship program? We've mentioned at least 2 that are out there that are freely available. Are people knowing how to get in touch, how to pursue that? So, I mean, even that sense, I think, of starting off within those 4 elements that you've identified would be an interesting starting place to say, okay, and then getting back to that ethical question, if we have someone who's expected to cover speech services, what is our responsibility as someone involved in funding decisions and working with teams to say, are they feeling well supported and equipped? One other element that we could jump into, and Rupa pushed this question, and obviously there has been a big change. If we talk about, what was a major step forward in terms of that sense of ad hoc, or as Adiola has done, of taking responsibility for training herself, what is that next phase? And one of the big changes that's happened through the COVID in particular experience has been the opening up of new technologies, of new ways especially if we talk about communities that are further from a center where, as Trina mentioned, it's really not possible for a family to travel 2 or 3 times a week. How does our new understandings of how to move forward with speech service influenced by, in some contexts, the availability of smartphones and virtual lessons and new practices that are acceptable, have been tested, that can lead in certain elements to progress in speech. I'm not sure if anyone has any comments on the idea of how the context in their situation has changed since the availability and of virtual care has emerged, and how that's informing some of our different levels of care.
Can I speak, Hugh?
Please, Professor Rupa.
Yeah, so I think the huge change for us through COVID and the huge change in the internet penetration and availability of phones has made this process of working with the community much easier, because this concept of coaching, supervision has become more available and more possible. And so I see the value, in being able to do coaching and even teaching for that matter. So I think it's actually become easier than what it was 15 years ago. But what is also true that we have more, healthcare professionals available, not necessarily SLTs, but other kinds of healthcare professionals also available, and when we don't have anything, that's a point to start. And I really like the framework set in that paper that says what this particular person can do and what they cannot do. And I think that helps us set up what type of services can be provided by a particular type of particular level of work. But at the end of it, like Debbie said, we have to keep pushing, because ultimately our goal is that any child should get the best quality of care. We don't ever take that off the table. It may look like a compromise, but I try to provide what is the best I could do at this point. Yeah.
Lovely. And of course, as we're saying, and in contexts where the resources are so different, that sense of progress is so critical, that it's not necessarily that this is either good or bad, but we're on this journey. As we always talk every week on this, we're on a journey towards comprehensive cleft care in low and middle income countries. And so how do we establish what's working well about what we're doing, but also map out those next steps? And just briefly, Sarah, the director of the mentorship program, MAGS within SmileTrain, please, your comment's great. I want to point to it, but please, what else would you like to say?
Yeah, no problem. I'm really happy to see everybody here, and this is such a great discussion. But yeah, I think something that I've found in my discussions with the mentees has been really just the impact on their confidence as well in delivering care. And I think that's something that, as speech therapists, we remember the early years of our practice and needing to ask questions and collaborate with other people. And that may not be an opportunity that some of our colleagues in LMICs have. So I think mentorship programs really have this role as well to kind of increase the confidence of our speech therapist colleagues and allow them to contribute in a more kind of outspoken way with their cleft colleagues and with their cleft team. So I just wanted to share that personal experience, but thanks everybody. This has been really
lovely, Sarah. Thank you. And lovely. Thank you for that pitch. Also, that speech therapy is meant to be done in a team. That interaction with the surgeon and the speech therapist and the rest of the team is so critical. So confidence building and that sense of a team coming around and really embracing the ability, the need for children to be able to fully communicate is such an important piece. We're almost out of time. I just want to make a quick shout out to Erica Bostock from South Africa in terms of some of the resources Operation Smile is developing and some of the training programs that they're developing. So that's there in the chat. Don't forget that. And then Penawan Yudi, our colleague from Northern Thailand, also talking a little bit more about that sense of when you have no trained speech therapists who are willing to live in your region. How do you accommodate for that? And she's actually reached out to some people like Man on this call from Myanmar to provide some of that care. Obviously, it's always a work in progress. So that brings us to the end of almost our time. I think we've got a quick summary here to say. A quick shout out to the Cleft Congress, where we're working on some of these interrelated topics. So carve out some time, March 20th. You won't want to miss it. The topic of this year's Solutions Conference is Inclusive Approaches, Lasting Change. Many people on this call have been part of the preparation process. We'll want to bring to you exactly what their solution groups have come up with. And if we go on to the next slide. There are some tips here about how you can make use of the circle. So if you haven't explored yet the Circle app, this is a place for continuing this type of discussion. We will post this video here, hopefully stimulate some more thoughts that we didn't get a chance to cover. There is so much there in terms of charting a path towards better speech support for every child born with cleft, and that aspirational goal of making sure that everybody has access to that in the cleft community around the world. So thank you very much. Stay tuned for the video. Do share it with your colleagues on your own team, and think about how you're engaging with these terms of teaching, training, supervision, mentorship, as well as if you're relying on non-trained cleft speech therapists in your team, what does that mean? And what titles are we using? How do we advocate well for everybody on our team to receive the support that they need towards that goal of having everyone feeling equipped to provide really excellent care? So a huge thank you to our panelists today, to everyone who's joined from around the world. Speech therapy is so close to the heart of the Circle of Cleft Professionals. We're so glad you're part of this, and we do encourage you to continue the discussion on Circle. Let's see if we can have some follow-up, potentially webinars or discussion points on this really important topic. Thanks, everybody. We'll see you next time.